I'm going to talk about novel approaches to pain management, some recent advances and future directions. And just in overview, the take-home message is that the analgesics we have now are very useful. We should all use them more effectively, but they have some limitations. I'm going to talk some about ways of improving efficacy and ways of reducing side effects. But I'm also going to talk about ways of approaching pain, particularly chronic pain, without analgesics, and a group of conditions that we'll call the strange pain disorders, including fibromyalgia, phantom limb pain, complex regional pain syndrome, reflex sympathetic dystrophy, where the evidence-based treatments rely more on physical therapy, cognitive behavioral therapy, a kind of rehabilitative approach rather than on medications. My disclosures are, I in fact work on making new local anesthetics, and I have research support and collaboration with several companies. I've been an advisor to CVS on opioid safety issues. If you're interested, Troy Brennan, who's now the medical director of CVS, wrote a thing in the New England Journal about 6 or 8 weeks ago on steps they're taking when an opioid mill prescribes opioid, when a physician who's a family practitioner prescribes opioid for 90% of their patients, and it's all cash and it's all of a certain set of risk factors, how a pharmacist might respond to that. I also have been involved in designing pediatric trials of some peripheral opioid antagonists like Dr. Greco talked about. I'll talk a lot about work from our group, and so if I use the term we, it means at least all the people shown here. I have a wonderful group of collaborators. And to break up this, I'm going to show a lot of paintings. And again, my disclosure is these are paintings by my wife. And they include a lot of paintings of infants and children. And the newest group of them is, in fact, a permanent exhibit now at the South End Community Health Center dedicated to our kid's pediatrician and my mentor in general pediatric clinic, Jerry Haas. So if you want to see them, they're at the South End Community Health Center. And that ends my disclosures. So more than 40 years ago, acetaminophen replaced aspirin as the routine analgesic in pediatrics. And so you might say, what could possibly be new about acetaminophen? We prescribe it every day. We still make mistakes with it. It's still the commonest acquired cause of liver failure in infants and young children. It used to be that the concentration of the infant drops and the pediatric liquid differed. The FDA has made strong attempts to try and have a single concentration. We don't have that for ibuprofen. So even within a same brand, you can get different concentrations of ibuprofen, and mistakes get made with that often. Dr. Greco talked about how for post-op pain and many other settings, opioid sparing is one of the aims of using acetaminophen or ibuprofen, but in your daily practice, these are the first-line things. So a kid with an earache, you're going to start with acetaminophen. But part of how we measure its efficacy, part of how you know what dose works and what dose doesn't, is using opioid sparing in kids having surgery. So just because we've done a systematic review of 6,000 pediatric studies of analgesics and all, analgesic sparing and opioid sparing turns out to be a useful way to measure drug response. So if you take groups of kids having ambulatory surgery and double blind, they get a rectal suppository of placebo, 20, 40, or 60 mg per kilo. You may say that's an absurd dose, but in fact, rectal absorption is so inefficient that the blood levels were not excessive from that single dose. You see here a dose response. You see that if on the y-axis, the percentage of kids who needed no morphine in the recovery room increased to 80% needed no morphine if you escalated the dose up to 60 mg per kilo. So we've all been prescribing rectal acetaminophen forever. It's clear that 10 mg per kilo is ineffective, that 20 mg per kilo starts getting efficacy, but it's incredibly variable. So if you look at either pain scores or blood concentrations, some kids get perfectly adequate concentrations, many don't, and it's really incredibly variable. What about in the youngest of kids? We know there's over 300 clinical trials of acetaminophen for analgesia in kids, but what about in newborns and very young infants? Here are two trials from the same group in the Netherlands, one using rectal acetaminophen, double-blind, and they got no morphine sparing. The other, IV acetaminophen, and they got morphine sparing. Some of it is simply the bioavailability of IV morphine. Some of it is how they did the rescue paradigm. Again, it doesn't mean we shouldn't prescribe rectal acetaminophen, but realize that it will be inconsistent. You can't go giving IV for everyone, but in a surgical situation, we use it for neonates having bowel surgery and all. It's a very useful agent. So the limitations of acetaminophen, you know, are moderate efficacy, erratic rectal absorption, hepatotoxicity, and overdose. IV is not a new drug. It's just more reliable in a post-op setting or in a bone marrow transplant setting in a kid with mucositis, or settings where you can't take it orally. Orally remains much more reliably absorbed than rectally. Nonsteroidal anti-inflammatory drugs and COX-2 inhibitors we all know well, and the best studied nonsteroidals in pediatrics are ibuprofen and naproxen. There's little evidence that they differ a lot in terms of efficacy at recommended doses, so that when you hear people say, oh, give ketorolac, it's somehow different. In fact, at recommended or equitoxic dose in randomized blinded trials, ketorolac is not a stronger drug than ibuprofen or naproxen. It has the fashion and flair of a drug that's given by injection, but in blinded trials seems similar. There's over 400 randomized trials of nonsteroidals in kids where you take kids having dental procedures or surgery or other things, and half get nonsteroidal, half get placebo. And in general, it makes pain scores better. It cuts opioid use by about 40–50%. The safety track record is good, but let's talk about what we mean for that. The large studies from pediatric office practice by Lesko and Mitchell, 80,000 kids getting ibuprofen or acetaminophen for fever, and essentially nobody came in with liver failure or renal failure. That's the good news. My nephrologist colleague will say, but nobody went and measured everybody's serum creatinine. Nobody looked at one's lifetime risk of nephropathy or hypertension from regular use of nonsteroidals. The best long-term information we have from repeated nonsteroidal use is in kids with arthritis back in an era when everybody with arthritis was on nonsteroidals forever. They're not now. Even there, the lifetime risk of nephropathy and of hypertension seems tolerably low in kids getting recommended doses of Tolmetin, naproxen, or other nonsteroidals that were commonly used long-term for arthritis. Classic problem in our everyday world is you're called about a 8-week-old full-term kid who's going to have ambulatory surgery, going to have an inguinal hernia, and somebody asks, can I give them ibuprofen? Can I send them home with it? Does it work? Will it make them bleed? We have remarkably little data on kids in that age group. Most of what we know for safety of nonsteroidals in the newborn period up to 3 months is from closure of the ductus arteriosus. So for those of us who did neonatology a while ago, there's a lot of randomized trials comparing ibuprofen to indomethacin for ductal closure, and overall the safety profile of ibuprofen looks a little better. And it looked pretty good in sick preterm babies, who have congestive failure, who have all kinds of things going on. So if you say, is ibuprofen probably a safe choice in a 3-month-old or an 8-week-old? Probably 2 days of dosing is low risk. We looked at 5 years of records of kids having ambulatory surgery at Children's and could not identify surgical bleeding that was ascribable to nonsteroidals in infants coming back for that. We looked long ago at a ketorolac trial, the first 3,000 uses of it, and looked at a randomized trial for tonsillectomy, did not show a major effect. You heard Dr. Greco talk about these concerns about nowadays everybody goes home the night of a tonsillectomy, or 80% or more of kids go home after tonsillectomy. In a previous era, they were all admitted. The risk factors are being under 3 years of age, having congenital orofacial anomalies, morbid obesity, cardiac disease, neurologic disease, and some of those kids get admitted, but there are places in the country where even most of those kids go home. What shifted for our otolaryngologist is deciding about relative risk. Ours used to be afraid of nonsteroidals and said, oh, I don't want them to bleed, give them opioid. There have been 3 meta-analyses on nonsteroidals and bleeding, and in fact, 2 of them didn't show an increase in bleeding. Surgical technique has changed considerably over the last 15 years, and ours now make round-the-clock ibuprofen, round-the-clock acetaminophen their core at all ages, and opioid for the older kid more than the younger kid. So that's, I think, a real practice change in recent years. I'm going to skip the part about opioids that Dr. Greco just talked about, including this work on novel ways of getting rid of side effects. These are in the pipeline. These are studied in adults. They're a while from pediatrics. So this next section is going to be about local anesthetics and regional anesthesia. Not because you're all going to go out and practice it, but as you send kids to hospitals for minor surgery and major surgery, just to tell you a little bit about both what has changed in this area and why it's become my own area of translational research. If you're going to have a big operation, if anyone here is going to have a joint replacement or a thoracotomy, the data are overwhelming that you should have you're going to be asleep, but you should still have some form of regional anesthesia. That for hip replacement, knee replacement, for thoracotomy, if you randomize people between getting either for thoracotomy a thoracic epidural or a paravertebral block versus not having any regional, you will have less pain, you will breathe better, you will use less opioid, you will have fewer pulmonary complications, you should have it. Similarly, if you're going to have a hip replacement, the only discussion is about which approach. Is it lumbar plexus catheter plus single shot sciatic block? Is it a epidural? Depends on how you manage the anticoagulation, but you wouldn't want to have a joint replacement without some form of local or regional anesthesia. Well, that's all people our age and people who have different medical risk. What about infants? And somehow you think the risk factors must be different, the benefits must be different. But increasingly, for both minor surgeries and for the pediatric equivalent of big surgeries, thoracic operations, major hip operations in kids with cerebral palsy, evidence supports doing regional anesthesia for it. But the techniques are different, the pharmacology is different. Over the last 25 years, we've done clinical trials and a lot of development in how to do these safely. Many of you know that there's a concern about effects of general anesthetics on the developing brain. And a group of us in North America, Europe, and Australia just finished randomizing 720 infants having inguinal hernias to spinal anesthesia versus general anesthesia with 5 years of neurodevelopmental follow-up to see what goes with that. But that required doing some pharmacology, doing some infant animal work, and figuring out how to do that safely. For routine surgeries, if you send a kid to Children's for a hernia, an umbilical hernia, or any small operation, it is standard of practice that along with the general anesthetic, you get infiltration of local anesthetic in the surgical wound. For minor surgeries, it's quite helpful. It reduces analgesic requirements. It makes it easier to do a general anesthetic. People wake up less dysphoric, and it's incredibly useful. And what I'm going to talk about later is ways of making that work even better. So if you infiltrate a wound, and you can cover all the afferents for surgery, and that's a big if, overall you get analgesic effects lasting with bupivacaine or ropivacaine 6 hours or so. That's something, but that's not the whole course of post-op recovery. So what's the literature out there? The literature is that we know how to perform in a safe manner with databases exceeding 80,000 cases from North America and Europe, how to do wound infiltration, how to do epidural analgesia at any age, how to do peripheral nerve blocks at any age. And what's changed with regional anesthesia is it's mostly not blind. When you think of when we all do spinal taps, we feel where we're going, we know the depth and all, and most of the time we get it, but sometimes we struggle. But what's changed with regional anesthesia in our practice and worldwide is using ultrasound or other ways to see where you're going in real time. Ultrasound machines have gotten better. We've gotten better at using them. They've gotten less expensive. And so in my own practice, I essentially never place an epidural without either using nerve stimulation through the catheter or ultrasound, or in complicated cases, fluoroscopy, to prove where I am. And I'll just show you examples, not to do it, but to understand what's going on when you send kids for surgery. So for all kinds of regional anesthesia, the ways of knowing where you're going include ultrasound, nerve stimulation, fluoroscopy, and a specific local anesthetic, chlorprocaine, for testing. Why is ultrasound useful? Well, in adults, when you do a block, if you're having a hand reconstruction and you do a brachial plexus block, you can do it beforehand in an awake adult, and they can tell you, it's getting numb now. Kids are asleep, and so you want ultrasound both to prove where you are before surgery. You want to know that you're next to nerves, not in nerves. You want to know that you're bathing around them. And for a sleeping child, it is a very helpful way of doing it. So just to show you pictures of a few examples. You have a kid who's going for a femur osteotomy or repair of a femur fracture. Most of the femur bone, most of the pain from that surgery is innervated by the femoral nerve. Femoral nerve, as we learned in anatomy, nerve, artery, vein. Here's the anatomy picture. Here's what it looks like on ultrasound. And so the femoral nerve is visible right next to the artery. You can pass a needle, see that you're giving local anesthetic that bathes around it, that you're not hitting the artery, that you're not piercing the middle of the nerve, but you're bathing around it in the fascial plane. And you can leave a catheter there overnight so that somebody having a rotting of their femur or an osteotomy, it's a very straightforward matter to take most of the pain away by a femoral catheter. If you're doing surgery in the lower leg, you can access the sciatic nerve at levels from the buttocks down to the knee. You can see vessels, you can see the nerve, you can see that you're bathing around it. Straightforward thing. One approach that's changed adult thoracic surgery a lot is most of the pain of a thoracotomy is from the intercostal nerves that go under each rib. And there's a space right adjacent to the spine called the paravertebral space where those nerves exit the spine and then wrap around under each rib. You can see that space and see that you're giving local anesthetic and that it's spreading outside the pleura in the space dorsal to the pleura next to the internal intercostal membrane and bathe the nerves there. We now do infant thoracotomies with those kind of blocks. We have not, knock on wood, had a pneumothorax from that. We've not had a nerve or vascular injury from that. You can even do LPs in your practice or epidurals in ours. And for example, I do a gene therapy study that requires giving lumbar punctures for treatment of spinal muscular atrophy. I can do LPs by ultrasound and see where I'm going in real time. You can see the epidural space either in axial view or paramedian view. So for big thoracotomies, for kids having NUS procedures, I think these kind of approaches make your post-op course better. A number of trials have said reduce pulmonary complications and some shorten hospital stay. Another way to prove where you are with an epidural is to nerve stimulate. And this is a guy in Canada who developed this. I wish he would have draped better, but it's his video. But anyway, showing a catheter placed in the caudal space. And again, if I show you that again, you get twitching. In infants, you can pass a catheter from caudal to any level and get twitching there, or as you go now to lower thoracic, you see twitching in the back muscles. You can prove that you're epidural, that you're not wrong-sided, that you're at a level you think you are in real time very quickly and inexpensively. For complicated situations, for people who, if I'm placing a port in a kid with metastatic cancer, general surgeon and I together will implant an intrathecal port. It's got to be in, it's got to be at the right level, it's got to work. We tend to use fluoroscopy. If I'm doing a case with Brian Snyder's one of our orthopedic surgeons who's going to do bilateral hip osteotomies, femur osteotomies, and 15 tendons in the lower body, and the kid has spasticity and their lumbar spine is curved, I'm going to use fluoroscopy to place an epidural to see where I'm going. And this just shows a guy who initially developed this technique in South Africa, who's now in Seattle, showing feeding a catheter up the caudal route, proving that he's at a high lumbar level for that. It's also feasible to direct epidural catheters to the side of the epidural space you prefer, and there's techniques for that. So all of these things have a whole body of controlled clinical trials saying that they can be done safely, they can be done effectively. Nevertheless, there's limitations to the local anesthetics we have now. If you're in your office with a 5-kilo infant and you're infiltrating with lidocaine for something, How much 1% lidocaine can you give? Well, 5 milligrams per kilo, it's a 5-kilo kid, that's 25 milligrams. 1% lidocaine is 10 milligrams per mil, that's 2.5 mils. So you can see that kids, if you don't do the calculation, you don't think about it, or a kid, classic thing is a kid comes for a tongue laceration to a community emergency department, the kid is going to scream. You infiltrate into the tongue, they're still going to scream. Somebody gives more, they have a seizure, bad stuff happens. So the limitations of the local anesthetics we have now are duration is too short. Sometimes you want it to wear off. If I had been to the dentist at 6 a.m. today, I would sure want it to wear off before I talked in this lecture. But if you're having your chest split open and you could numb the chest wall once and have 4 days of analgesia, that would be rather nice. You would also like sensory selectivity. It would be nice to have a labor epidural which is truly has no effect on motor blockade or autonomic function, so women could walk and push and feel mild pressure and not be hypotensive. And I have collaborators who work on that part of things. What I'm going to talk about is ways of making one last for 3 days. And ways of having them not cause cardiac toxicity or seizures. So again, my disclaimer is I work in this area, and if these become commercially successful, Children's Hospital, my collaborators and I could someday get royalties. But several groups have looked at ways of making a 3-day, 5-day, 10-day local anesthetic. One by taking existing drugs and making them controlled release, and we worked on that for a number of years. The other is new molecules. So one that's recently come onto the market is called Exparel, and it's a liposome of bupivacaine, or a depot foam of it. It's had 4 published trials in hemorrhoidectomy, bunion surgery, breast reduction. They've figured out some of the kinetics. It has some effect on pain scores going out the second day. I am very biased. I think it has some limitations. The way we've approached it is to take new molecules or old molecules used in new ways. And these are local anesthetics, as you know, are drugs that block voltage-gated sodium channels. There are molecules that come from either the sushi, the puffer fish that makes your lips tingle if it's prepared in a certain way, or the algae that cause red tide so that you can't eat shellfish from certain places if it has that. It turns out there are ways of using molecules in this class to be not toxins, but usable local anesthetics. In your handouts, there's a lot of detail on it. I'm going to skip anything having to do with rats, except to say that we, back in the late 90s, started looking at ways to make these usable local anesthetics, and that I've shown you sciatic blocks in humans. We, in fact, do sciatic blocks in rats all the time, and showed that these are incredibly synergistic with existing local anesthetics, and that they have cardiac safety and are usable. So I'm going to skip over all that. But then, by happenstance, a group in Chile, Chile has a huge shellfish industry, a huge problem with red tide, and a general surgeon who looked at our work found a strain of cyanobacteria that could make them a lot, and started doing clinical trials. And the short version of it is we're now, and he showed it to be better than bupivacaine in a double-blind trial of 137 adults having gallbladder surgery. And we're now in the US doing trials of this, showed that people recovered better, had better global recovery parameters. So I'm going to skip that, except to say that part of my time is involved with trying to get this to market in the US. So where do we need to do better with acute pain? We need to do better with non-intubated neonates following surgery. We do pretty well with scoliosis surgery. We need to do better. If you look at kids in our hospital who have unrelieved severe pain, I'm going to show you in a second, sickle cell disease, even when you give someone a PCA with a basal infusion with as much access as they want, for many people, the dose of opioid that works for sickle cell disease is the dose that makes you somnolent and hypoventilating. The electronic medical record allows you to track every pain score in the hospital. And this is the distribution of 1.5 million pain scores over 3 years of all hospitalized inpatients. So the good news is that the median score is a 0 of all patients. The mean score is a 1 point something. But we've done these in-depth analyses of all the high scores and the features of them. And again, sickle cell patients, people with developmental disabilities and screaming of unknown origin, the kid with a white matter disorder who screams all the time no matter what you do, and people with chronic pain and psychiatric illness and profound psychiatric disease manifesting as conversion and other somatoform conditions. So I'm going to shift gears now, and I apologize for moving very fast. I'm going to talk a little bit about chronic pain, and suddenly we're going to talk less about medications and more about other ways of approaching it. We founded our pain clinic back in 1986. It is the first pediatric pain program in the world. It remains the busiest. It's a collaboration that involves multiple departments, involves physicians with multiple backgrounds. We have 4 neurologists working with our group. We have a group of people like Dr. Greco and myself and Dr. Lin who are trained both in pediatrics and anesthesia. We have psychologists. We now have a psychiatrist, physical therapists, nurses. We have a main clinic on the Longwood campus and programs in Waltham that I'll mention a little. Dr. Lin will talk about the acupuncture program. There's a program for treatment of kids with chronic headaches and a day hospital partial pain rehabilitation program. In your world, you see not, by and large, children, unlike adults, don't have chronic daily pain. You know, if you're an adult physician, you have the 70-year-old with osteoarthritis who hurts every day. In your world, it's the kid who has headaches 3 times a month, has abdominal pains 4 times a month. And if you look at school absence in the United States, in fact, 20% of missed school days are the kids with headache and abdominal pain on a recurrent basis. And most kids are growing and gaining weight, and you know algorithms for each of them, and it does not mean that every kid with a headache needs an MRI. It does not mean that every kid with chest pain needs an echocardiogram. In fact, you couldn't do so. 500,000 children in the United States see a doctor with chest pain every year. You don't want to miss the one who has an anomalous coronary or a cardiomyopathy, but most don't. And for most, a history and physical is your guide for what to test and what not. And just like if you're an adult doctor, your disability means not being at work. In pediatrics, your job is hard and you are busy. And if you're going to ask a single psychosocial question, you ask, are you going to school? And if not, why not? And just like workman's comp in adults is the graceful exit from your social role, there's situations where home tutoring has a useful function, but there are times when home tutoring or web-based finishing high school can be like the workman's comp of childhood, a graceful or a socially sanctioned exit from your social role. And so asking, well, if you're not going to school, is it because of pain? Is it because of bullying? Is it because of you have learning and attentional issues that haven't been addressed? Is it because your parent says, I'm not sending you back to school until you're fixed, until you're all well? Is it because of over-enmeshment between parent and child, a lonely parent that wants the child to stay home? So you think about those things every day. What you've heard about some are kinds of pain that we think we understand mechanistically. We think we understand pain after surgery or inflammation or cancer or things like that. The features of what I'll call understandable pain are we know a lot about peripheral and spinal mechanisms. We can make animal models. There's good animal models of arthritis. There's good animal models of sickle cell disease, of cancer pain. These respond in certain ways to analgesics. And if you numb the part of the body that's involved, people report getting better. Pain due to abnormal functioning of the nervous system, either injury to nerves, inflammation of nerves, or abnormal excitability in the nervous system, in adults is a major public health problem. So diabetic neuropathy, postherpetic neuralgia, a whole bunch of these kind of problems are big and common problems in the adult world. In general, the medications that have evidence for helping are anticonvulsants and some subclasses of antidepressants. But they're not magical. And I just want to show you that even though gabapentin is marketed, that postherpetic neuralgia is the easiest to study in adults, and it doesn't make people's pain scores go from 8s to 2s, that in these placebo-controlled trials, it may make your pain score on average go down by 2 points. And even when you go up to 3,600 milligrams a day, if your pain scores on average go from 6 to 4, it's better than placebo, but it's not magic. I would submit to you that if you're a 17-year-old trying to study for SATs, you cannot take 1,800 or 3,600 a day of gabapentin and remember anything. Some people do, other people are goofballs on a quarter of that dose. So what you've heard from Dr. Greco are that in making decisions about who you give medications to and who you treat in different ways, it depends on the nature of their chronic pain, and that somehow there's something different about, how many of you have seen Annie Hall and, remember Woody Allen, Annie Hall? So when the world is divided into the horrible and the miserable, so some of the patients we see in the clinic are the horrible. They're people with really bad diseases. This is someone who had a hemipelvectomy at age 3 for a Ewing sarcoma, and she didn't die. And you don't have to be a radiologist to notice that there's a missing pelvis and a femur that's just sitting in the breeze. And for most of the following 20 years, she walked with her femur just kind of floating there and had pain from as early as she could talk about it. But she's now 30 and handling that kind of thing forever. So some of the people that you consider have diseases that are bad, but they're going to live a very long time with. Some of the people we see are people with, like adult pain clinics, people with unfixable spine problems. Some of them are fairly fixable. So a very common adult kind of problem are lumbar disc herniation and radiculopathy, where we see collectively between us, orthopedics, neurology, neurosurgery, more kids in our database than in the world published literature combined. We do transforaminal epidurals for some of them, just like in the adult world, and have had a good outcome of 5-year follow-up. We see kids with diseases of short lifespan. In pediatric palliative care, in fact, there are more kids with neurologic diseases than there are with cancer. And neurologic diseases of uncertain longevity are a major challenge in who you're going to treat with which analgesic. But going back now to, for common conditions and for the strange conditions that I'll talk about, there's an enormous body of evidence that a short course of, about 3 more minutes, a short course of cognitive behavioral therapy is evidence-based, that it improves pain, improves functional status in kids with migraine, recurrent abdominal pain, kids with a whole range of chronic conditions. And the challenge is how to deliver the service, how much, where you find people, how you get it in people's healthcare system. We have people researching group-based, web-based, other curricula for that. But I want to close to tell you a little bit about some of the other kids we see in our clinic. And these are what I'll call the strange pain disorders. So phantom pain, reflex sympathetic dystrophy or complex regional pain syndrome, fibromyalgia, focal dystonias, or kids where it may make sense to call it pain as a habit or a memory trace. The features of some of these are that they are non-dermatomal. It's been hard to make realistic animal models. You can make a rat seem kind of like they have fibromyalgia if you sleep deprive them and stress them enough, but it's not a great model for it. And they have inconsistent responses to analgesics. There's long-standing debate about psychological factors, and in general, psychological factors affect not whether you're going to get one of these conditions, but how you cope with it, how you deal with it, how you manage it, not whether you are going to get it or not. If you look at brain imaging of people with any of these disorders, your brain is changed. If you take amputees and do, when we all learn the neuroanatomy of our sensory and motor homunculus in medical school, we learn them as kind of fixed wiring diagrams. Except if you take people after an amputation, their homunculus is distorted or smeared, and there's more distortion of it in proportion to how much phantom pain you have. And in people who you do effective therapies, either mirror box or myoelectric prosthesis, you tend to restore the pattern back to a more baseline type homuncular pattern. And there's evidence that in some of these conditions that the descending pain inhibitory pathways, that we have structures and pathways in our central nervous system that tune out pain, that it is adaptive to pay attention to it sometimes, but when our ancestors were running from tigers in the jungle, it was adaptive to not notice that you've stepped on brambles and things like that running through the savannas. And so we have very strong methods that take attention away from pain, and that our experience of fear or the meaning of pain in a very mechanistic way changes how much the amplifiers are dialed up or dialed down in your spinal cord and in your brainstem. So a condition that we treat a lot is called CRPS, or RSD. We've seen 1,300 kids with this over the last 25 years. And as you see in the picture, a minor injury, a fracture, a sprain, but the leg gets swollen and purple and mottled and incredibly hypersensitive to touch. And it can jump to the contralateral leg following unilateral injury. It can spread. It's remarkable in its epidemiology. It affects girls about 8 times as often as boys. In childhood, it's the legs more than the arms. In adults, it's the arms more than the legs. But the remarkable thing is, if you just move it and touch it, even though it hurts, you can make it better. You don't fix diabetic neuropathy by walking it off, but you can fix CRPS by, in a very particular way, reconnecting your brain to your limb. And so the treatment is a very specific kind of physical therapy, occupational therapy, cognitive behavioral therapy. We did retrospective studies of it and got funded by the NIH to do prospective studies of it a number of years ago, showed that a kind of intensive outpatient rehabilitation improved pain scores and function scores. We've had the good fortune of having philanthropic funding by Dick and Sarah Page Mayo to open in Waltham a day hospital for the more severely affected kids for 5 days a week, 8 hours a day, for kids from far away, a low-cost apartment nearby, and a structured regimen for this, and a curriculum for parents. If you have patients like this, call up. We're happy to discuss them with you. We're happy to treat them. The outcomes, published outcomes are good in rapid improvement in limb function scores, reduction in disability scores, improvement in pain scores. And again, a part of this is viewing some kinds of pain as a distortion of the brain's map of the body. And time doesn't permit, other than showing you pretty pictures, that we have a whole effort in doing brain imaging for this. So David Borsuk, Lino Becerra, Alyssa LaBelle, and their colleagues look at structural and functional changes in specific brain regions, changes in regional connectivity that improve when kids get better, though some of the changes are persistent features even in people who are clinically better. I mentioned that there are ways of treating phantom pain, for example, with using a prosthesis, using a kind of immersive virtual reality or graded motor imagery that are techniques that psychologists often do together with physical therapists, not because these are psychogenic disorders, but because you can use attention and activation of your brain's capacities to process differently and to change the brain structurally and functionally. So I apologize for this whirlwind look through some of this. Some of this was meant to be practical, but some of it was just to give you a flavor of what kind of research and new treatments are going on. I think that there are new treatments out there that are improving. I think some of it involves better use of the medications we already know, new medications, but also a growing understanding of how certain kinds of chronic pain involve structural and functional changes in the brain and spinal cord. So thank you for your attention on this.